Okay, so our second to last patient is Edward Teach. He was admitted to the hospital with flu-like symptoms. He has a history of Addison's disease. That's going to be your first clue. He's also confused and agitated, and he's lethargic. So when we look at Edward's lab values, we can see, it's kind of opposite of Cushing's disease. Instead of having a high sodium, he's going to have a low sodium, and his potassium is going to be opposite. What's happening here is that he doesn't have mineral corticoids or glucocorticoids, which would explain why I don't have vital signs on there, why he would be hypotensive. His signs and symptoms are that of dehydration. But you look at that sodium and you go, wow, what's going on here? So that we can see that he's really dehydrated. He's also very hypoglycemic. So when it doesn't make sense, the thing you should be thinking about is Addison's disease. So what would we see with Addison's? We would see that he has bronzing of his skin. He's going to be very weak. He's going to have, we would want to be doing some vital signs on him. We would want to be doing eyes and O's, daily weights. We can see that his serum cortisol is really, really, really low. We would anticipate from the healthcare providers some hydrocortisone. Hydrocortisone IV is the only thing that's going to turn this around. And when you give hydrocortisone is a mineral corticoid and a glucocorticoid combined. So when we see this, we would anticipate that he's going to need it. He's going to need it about every 6 hours until we get his cortisol level up. Some of our nursing diagnoses, fluid volume deficit. We would anticipate a deficient knowledge, because he would be, he didn't know that when he had flu-like symptoms, he should increase his dose of glucocorticoids and mineral corticoids. So our nursing interventions, all of those for fluid volume deficit, daily weights, eyes and O's. He's going to need to be near the nurse's station. He's going to need seizure precautions. He's going to need a cardiac monitor. He's going to, when we teach him, he needs to take a third of the dose, or 2/3 of the dose in the morning and a third of the dose in the afternoon. That follows the diurnal rhythm, or the circadian rhythm, when our bodies normally release our glucocorticoids and mineral corticoids. He's also going to need to know that he's at risk for infection, and we need to teach him how to take his meds, what to watch for, double his dose if he gets stressed, because we know that when we're stressed, we release more of our mineral corticoids and glucocorticoids. So under periods of psychological stress or physiological stress, he needs to increase his dose. Okay, Henry Morgan, one of the last of our captains. He was admitted to the hospital with kidney stones. He has no other medical history. We can see that he's high, or that he's tall and his weight's okay. What else do we need to know? When did the kidney stones happen? What is his pain level? Why is he high? So when we look at this, his calcium is 15.2. His parathyroids are high. So he's got a hyperparathyroidism. What would be some of our assessments? We would assess for polyuria. We would assess for muscle weakness. We would assess for seizures, because we know high calcium causes seizures. We would anticipate from our healthcare providers something that's going to help lower that. And we would anticipate that our healthcare provider would order a lot of IV fluids. We know that they need at least 3 to 4 liters of fluid a day to help excrete all that calcium. We can see with hyperparathyroidism, like our Cushing's disease, it's pulling the calcium out of the bone. So we're going to see this thinning of the wall, or this thinning of the bone. And you can see it here, and you can see it way in the back here, where we've actually sucked out a lot of the calcium because of the parathyroid, and now we have this weakened area. So some things that we can use are biphosphonates, and biphosphonates are going to pull the calcium from the blood and pack it back into the bone. So he wants a conservative approach. He's got alendronate, which again is a biphosphonate. He's going to take 70 milligrams weekly, and he's going to be on furosemide. Furosemide is going to help get rid of our sodium and our potassium and our calcium, which is what we need here. So we're going to teach him about alendronate. He needs to take it first thing in the morning, sitting up with a full glass of water, because it can cause esophageal ulcerations. The furosemide, he's going to need a hyperkalemic diet, or he's going to need more potassium in his diet, because we know that we're going to be excreting that. It's going to also work on the sodium, which is already low. So he may need a high sodium diet. Jacote Delahave was admitted for our transphenoid hypophysiectomy. Transphenoid hypophysiectomy is done for pituitary tumors. And what they do is they actually go through the nose and they remove the tumor. And I had a really cool video I was going to show you in class. Unfortunately, we're not in class. So some of our assessments, we're going to be assessing for any bleeding. We're going to be assessing for any fluid that comes out of her nose. We're going to be assessing that for glucose. We know that mucus is protein. Cerebrospinal fluid is glucose. So we want to assess anything of that. We want to keep the head of her bed elevated. Oh, here's my picture. So they actually go through and they remove that tumor. So post-op assessments, again, making sure that we don't have any glucose coming out of the nose, anything. We want to keep the head of the bed elevated a little bit. We want to be, we don't want her blowing her nose. We don't want her coughing. She may be on some antitussives. Anything that's going to increase that intracranial pressure, we want to avoid, because that can pop one of those little sutures there, and then, oh my gosh, we've got problems. All right, so I'm hoping that we hit all of our unit objectives. We didn't cover hyperaldosteronism. Don't worry about it. There isn't any exam questions. I will see you all on Wednesday, and have a good day.